Okay, you're all set.
All right, thanks everybody. Welcome to the special meeting of the Budget, Capital and Personnel Committee on August 18th, 2020. I would like to just ask for, and we do need to finish by 5 o'clock so that staff can make a transition to the legislature meeting. I would like to ask that we take resolution B first. We have two resolutions. Take the Tompkins, the TC3 budget, public hearing for the budget first. I think that'll be pretty quick. And then go to the Cougar Health Systems resolution, if that's okay.
I'll move it.
All right, moving the resolution on the public hearing, seconded by?
Oh, Mike's here. I'll second. Sure.
Second by Shauna. All right, moved by Dave, second by Shauna. I would just point out that Kathy sent out a note this morning that the meeting with TC3 has been scheduled now for next Wednesday, August 26th, 5:30. And then we'll get a full presentation of their budget. We do have a lot of material in our legislature packet that we already have, but we'll get we'll get a presentation and a chance to ask questions next week.
I think there'll be some updated information provided too.
Okay. All right. So this resolution just sets the public hearing. Is there any discussion or any questions?
Martha?
Yeah, Mike.
I did see the notice about the meeting next week with on the budget and the invitation that we're going to have to Cortland legislators. I just want to make sure that the Cortland legislators are able to participate, because apparently they don't use Zoom. They use something called WebEx. I don't know how that is. So if we send them a link, do we also have to send them information on the way Shauna taught me to download it so that they could then listen to it on Zoom? I wouldn't want people over there to not participate because they don't have the technical capability of doing that.
That's a really good point. Is that WebEx? Is that the state uses something with something like that name?
I don't know anything about it, except that's what I was told by a legislator, that they didn't use Zoom.
So we can, I can just make the county administrator aware of that, and that I'm sure their IT folks can work with them to ensure they download it properly. It's just another online meeting platform, similar to Teams or Skype or anything along those lines. It's just a different format.
I don't know how big their IT department is. That's the only thing I don't want to have to hold their hand, but we might have to.
Well, the county administrator was their former IT director, so hopefully he can.
I know. I know.
I can email them and just say, want to make sure that they understand it's a Zoom platform versus a WebEx.
Thank you.
No problem.
Thanks a lot, Jason. I've been on a couple of calls with the state using WebEx or WebEx.
Yeah.
And it's clunky. It's definitely not. Zoom, it just works pretty much. So thanks very much for following up.
No problem.
Right, ready to vote on the resolution. Dave McKenna.
Yes.
Shauna.
Yes.
Mike Lane.
Yes.
And I'm a yes. And so that's unanimous. And just to be clear, that Deborah Dawson is excused from the meeting. She told me ahead of time about her TCAP meeting. I just forgot. So thank you. The second resolution authorizing an appropriation for the Contingent Fund and on a contract for community surveillance testing for COVID. Can I have somebody put that on the floor? Shauna moves.
Second.
Dave seconds. Thanks very much. All right, this is something, Jason, where we got this today. We had an introduction to it last week, but you sent a lot of information out today. A summary of this for us.
Right. So I can summarize it. So the last discussion at the 10th was, let me back up a little bit, I guess. So in March, when COVID came into the community, Cougar Health System, CHS, set up a drive-through testing facility with the expectation that reimbursement would be received through the insurance carriers. They did a wonderful job. They were probably the first private group to set it up, and well before most of the state facilities were set up across the state outside of New York City. And it has been a key component to our ability to manage the disease and surveil the disease. And we've worked with them in being able to purchase avionics and testing equipment, which has helped turn around the testing timeframe. So if we remember back to March, it wasn't that long ago, testing recovery, and testing response or return was 6-7 days long. And in fact, the rest of the country is going through those issues with laboratories that have taken so long to respond. Here, it's same day or within 24 hours because of, largely because of Puke Health System's efforts to improve the process, and also our assistance as well as the cities and other community funders. And around the beginning of July, they received notification from all of the insurance carriers, health insurance carriers, that they were only going to be reimbursing for medically necessary testing. Medically necessary is defined as symptomatic individuals. So that if you're symptomatic, if you have been exposed to a known positive COVID patient, or you have an upcoming medical procedure of some sort. And those are what was considered medically necessary, which meant that they were also telling them that they may claw back reimbursements all the way back to March for non-medically necessary, which is how the medical billing world works a lot of times. So that essentially has triggered them to start discussions about changing their approach because they're not going to get reimbursement for it. When we talked about this at the beginning of July, we started to say, well, let's get the state involved. Amy was was on part of some of those conversations with me and the state, our representatives at the second floor, Kara Griffin, and then also some of the the testing gurus that the state is using and giving guidance to the governor and Department of Health. They recognized the value of the testing facility, and our state was, well, why don't you contract with them directly to continue this? It's an important piece of the puzzle. They were an important part of phase 1 reopening and the region's capacity to be able to test. At the end of the day, what came back from the Division of Budget is, no, we're not going to fund this. And that was multiple conversations, multiple meetings. So from that point, it was, all right, CHS, what would it be if we were to pay for the local share of a test? And that's what we discussed a little bit, is us just paying the local share, or essentially a 12.5% equivalent to the cost of a test. And the 12.5% came from generally what was considered a local share if they were to seek reimbursement for the cost of administering tests. FEMA reimburses for 75%. Generally, under most circumstances, the state reimburses for another 12.5%, and there's a 12.5% local share. The state is not committed to the full 12.5%, but what we started the conversation with is, well, why don't we will pay for the local share of this. Over the last week or so, and further discussions with CHS, the discussions really pivoted to what really works more effectively and cleaner is that we contract with CHS. We pay the full cost of the testing per test, and then we seek reimbursement for the 75% from FEMA, and then from the additional 12.5% from the state, therefore leaving us with a net impact of 12.5% for the cost of the test. Basically, there are several reasons on why it becomes complicated for CHS to submit reimbursement. One is that we deal with the same issue, is that when we go to seek reimbursement for a response, we don't always get every piece of personnel that's reimbursed, primarily because FEMA says if you were normally going to pay this staff member to work in normal circumstances, you are not necessarily going to get reimbursement for this position. In fact, you won't. You may get it if it fits into certain criteria where the position was solely committed to the response. In that instance, and that's somewhat discretionary, and it's not always a set clear path for that for FEMA to set that reimbursement. In this instance, if we were to take the first option, CHS would have to basically go through a cost of service analysis to get reimbursement, and there's probably greater circumstances due to the multi-scope of the testing facility as to what would be reimbursed and what wouldn't be. If we were to seek reimbursement, we're contracting for the service. It's a set unit cost, and that's the extent of what we are reimbursed, 75% of the set unit cost. The other piece of the puzzle that gets a little convoluted is if we were to pay the local share, so to speak, of CHS's share, that would actually be counted against the revenue or the reimbursement that they would get for FEMA. So it'd actually be considered revenue generation for CHS.
Say that again, Jason.
So if we were to pay CHS the local share as we were categorizing it, it would count as revenue, and actually FEMA would only reimburse for the cost less that revenue. So for example, to answer the question that was posed at the BCP meeting is, can we charge for it? Well, we certainly can charge, but that will be taken away from our ability to recover revenue from or reimbursement from FEMA. So it will be the cost after we receive that revenue. It won't be the unit cost, if that makes sense. Basically, what they try to prevent is folks from generating or making money off of FEMA reimbursement. I mean, FEMA reimbursement isn't intended for you to generate revenue. It's intended for you to offset costs related to a disaster. A question came across from Henry Grandison about the Rheonics machine. We actually didn't purchase the Rheonics machine with at the end of the day with the expectation of seeking FEMA reimbursement, primarily because of the nuance of this issue of revenue generation. We used HHS funding that we got from the CDC earlier in March when we did that. And it was also a known commodity because we had received that money and we could get that reimbursement. So that kind of evolved over the past week, where the proposal now is that we pay for the full cost per test, and then we take that cost that we've paid for and then submit the reimbursement to FEMA, get the 75% reimbursement, and then submit it to the state if they're going to reimburse us for the 12.5%. And then our net local share at the end of the day should be the same, 12.5%, but we're going about it a different way because we're floating the cost and then seeking reimbursement. As this conversation, yeah.
So if we charge the client, the person, $10 a test, let's say, that comes out of the FEMA reimbursement. It doesn't come out of our payment.
Right. So it's going to basically reduce the cost of the test, and then that's what we would submit for reimbursement. You know, it's going to deduct the amount of reimbursement we get, basically, because it's revenue generated.
Okay, it doesn't replace our share.
No.
It replaces FEMA's share.
Correct.
Okay.
Correct. Yeah, that's a good way of categorizing it, Martha. You know, what happened as this transformed over the week? You know, we confirmed with FEMA again that a community testing contract is something that is reimbursable for municipalities to submit to FEMA. They did confirm. Our rep, Jess Verifus, Doer, verified that. I also asked, you know, from a cash flow perspective, I need to know what's the typical reimbursement. You know, you hear war stories and horror stories about FEMA reimbursement. The response was, well, they can't necessarily guarantee it. What they're hearing around is that there's a 4 to 6 week reimbursement schedule. So when I showed you some analysis, I kind of showed you what a 4-week schedule would look like versus a 6-week schedule. That doesn't mean a whole lot at the end of the day, as long as it's received, because the net impact is still the same. It's more for a discussion with Rick, which we did have, about, you know, all right, what's our maximum outlay before reimbursement starts to kick in? And it's something that we can manage. So at this stage of the game, what we're bringing forward, and Frank and I'm sorry Frank couldn't be on the call. He's on another call now. You know, the discussion we had was, you know, what's the value of this? Is this something we should be doing and recommending? And the discussion came down to, well, if we're able to identify, you know, cases, particularly asymptomatic cases, and we have the ability to isolate them early, and so preventing the spread of the disease, it's exactly what we're trying to do and why this was up and running and so successful in the first time, which is identify positive cases as quickly as possible, isolate them, and prevent, you know, community spread of the disease. So after we did some modeling with potential unit costs with reimbursement, and we came up with a 10-week model. This $300,000 just about captures estimated anywhere between 750 to 1,500 tests per week, which is a vary range, so about 15,000 at the most tests over a 10-week period. And assuming only FEMA reimbursement, this is our total net cost would be around 300,000 within range. What we didn't factor in there was the state reimbursement. Obviously, if the state reimbursement comes through, we would then submit, and that would be less than this $300,000. But that's how we came to the amount. And really what we said is let's try a 10-week testing period and see what happens. So a lot of things can happen in the 10-week period of time. Anywhere from cheaper cost for administering the test as well.
And our contract would be adjusted if the cost goes down.
Absolutely. That's some of the things we talked about yesterday. There would have to be flexibility that if the cost of providing the service decreases for a variety of reasons, we're going to be subject to that.
Do we also have to pay if the cost goes up?
Well, obviously I wouldn't want to do that.
Right.
I can't see it going up only because they're gaining in terms of economy of scale and the efficiency of doing it.
Okay.
Adding more testing equipment, they're being more proficient at it, they're doing more of it. They're partnering with other partners to be able to expand capacity.
Okay. I hope that's written in the contract.
It will be, the real reason is that I think the cost has the ability to go down. So we would want to lock in that unit cost, and when the ability of it is to go down, we would have that discussion again.
Okay. Anything else in your introduction?
That's kind of the overview of it. It's asking the question about the value of it. It's consistent with what we're trying to do in containing the disease. I did answer some of your questions as quick as we could. Roughly 17%, about 40 of the 250 or so positive cases were asymptomatic. So 40 out of 235 cases were asymptomatic. That's 17% of the cases. If we're able to identify a few of those and prevent the spread of the disease, I think it's worth its weight in terms of what we're paying for.
Were those people who were who came in because of contact with somebody else but didn't have symptoms?
I asked the questions because some of them could be also preoperative screening.
Right.
We'd have to dig into the details of the 40 of them, but I think the answer to that question, it's all of the above. There's probably some essential workers that were asymptomatic. There's some individuals that may have been exposed but didn't have symptoms, and there were some that were preoperative. The point is we know it exists, and we know we've been able to identify it where otherwise, if we didn't have testing available, we wouldn't.
Thanks very much. Annie Corman, welcome.
Thank you. So thank you for answering the questions, Jason. I haven't read through all the answers, but I read through the one that you answered of mine. So one question I have, or a thought, is that I wasn't thinking before that, we should charge people. And so I've been trying to be open-minded. I've heard people mention, whether they thought, we should charge people or not, or we wanted to. So just one thing to think about is, even if it would lower the amount that we would get from FEMA, actually in the long run, it wouldn't lower the amount that we'd get from FEMA if we charged, because we'd have the money that we charged, is my understanding. But if we charge something, would that, slow down the number? Personally, I would like to see as many people get tested, but are there some people that are just kind of freaking out and are going every week? I don't know. But if we did charge for that, then say $10 or even $5, that might slow it down, a little bit. And if it did, that would lessen our overall costs because there'd be less people tested. So that's one thing to look at. Not that I'm advocating for that, but I just a thought in my head. Sure. And that's it right now. Thank you.
One thing I would just put out there for thought is that, we've done, before this issue became an issue, and we wouldn't be having the conversation if there weren't obstacles that have been created. We've done what we can to minimize the barriers to get testing. We've provided a transportation method of which we don't charge for. At the initial onset, it was a conversation that, even there's no form for, for certain identification to ensure that people have access and no one will be turned away. And I think when we start talking about this type of surveillance testing, what's the value of having a charge, and what's the harm of having, if someone wants to get tested every week to be able to give themselves the security and surety that they're not positive, what would be the harm in that? Just a thought for consideration in this case, and in this instance, charging for the service, while I think we could do it, it may throw a little bit of complication and things in terms of just documentation and so on and so forth, but is there a real value in charging for it when we're talking about surveillance testing to ensure that the spread of the disease doesn't continue?
Can I just comment back on that?
Yeah.
So yeah, I was looking at the numbers. So like, if it's, say it's $10, I mean, and I'm not advocating for that again, but say we charge $10 and, and so that's what was based on our figures here for, if we did the 10-week, and there's 775 or 750 tests a week for 10 weeks, that's $75,000. So that's nothing to sneeze at. So that might cover the costs of, figuring that out. Possible,
Right, but that doesn't save, that saves FEMA $75,000. It doesn't save us $75,000.
It would save us, what I'm saying is it might save us in that less people would get tested.
Right.
Does that make sense?
I understand that. I guess that's somewhat contradicting to I think what you want to do when you talk about surveillance testing. I mean, when you talk about surveillance testing, you want to test people frequently to identify the disease as quickly as possible and contain the disease. For example, and I'll just use what Cornell is attempting to do, is test people twice a week. The intent there is to that, if there is if the disease is spread, it's identified as quickly as possible. The individual is isolated and the disease spread is contained. So the surveillance testing perspective, the intent of it is not to limit the amount of testing. The intent of it is to test regularly so that you can continue to monitor whether or not the disease is spread as quickly as possible.
Okay, so if we went with the scenario where it was zero, so we didn't charge for it,
right?
And before it was pretty common knowledge that nobody could just go get tested unless you were an essential worker, unless you had those other criteria that you talked about. So this just could be opening up a whole new thing where anybody could go get tested for any reason, because that was not the thing that was going on before.
Well, essentially at July 1, the governor pretty much said anybody's eligible to go get tested. There is no more criteria. And when you think about it, a lot of the criteria has been expanded up, to that point to which he pretty much said anyone can get tested. So I don't think a lot would change on the ability of, my take on it is a lot is not going to change with respect. You're not going to see a huge wave of folks all of a sudden come and get tested because of this change. Essentially, what you're going to be allowing is the continuation of what has happened in the past and what CMC has allowed to get tested before based on that criteria that the governor set, which essentially is workers in a variety of different openings of phases, protesters. The criteria is pretty much open as it is. I don't know that it's going to, I don't know what this agreement would change that to increase the number of participants. If anything, what it would probably do is it's only restrictive to Tompkins County residents. So, there may be less activity at the site because outside residents won't be able to get tested under our contract.
And you think 750, or they have the data for 750 per week? We're going under, I'll call it surveillance, or I guess that's maybe what we're calling it, just surveillance testing, right?
I mean, that's a range of 150 to 300 a day is roughly 750 to 1,500 a week. Those are kind of ranges of numbers of what we have seen, and it depending on how it fluctuates. You could have a high of 500 a day. You could have a low of 75 or 100
right.
a day. We try to
clarify, Jason, the question was just, that was just surveillance.
Yes,
They've had that many that are just surveillance that didn't fit reimbursement.
correct.
150, on average. Okay, thank you.
Shauna?
Yeah, thank you. So I actually was apprehensive about this in the last budget meeting and even yesterday, just because it's a lot of money. And right now we don't have tons of money to throw around. Actually, we have zero money to throw around. And not that we ever did that before anyway, but I think even more so than ever, we're watching every penny that leaves the county, and we're making sure that our dollars are counting. And I had a conversation with Jason earlier today. We had a reopening meeting this morning, and Dr. Stallone was on the call. I asked him some questions, and the one thing that stuck with me in our conversation, Jason, was that if we're able to catch 5 people per week that are positive, imagine the impact that we're going to have in our community. And I mean, we've done such an amazing job. And part of the reason why we are a state leader, and if not a national leader, is because we've had access to testing. And while typically I think we're very quick to say, the county, the state should do this, the federal government should do this, no one's going to do it for us. That's the reality. And I think that if there is FEMA money there, we need to take advantage of it. I see the hospital in saying that from a cash flow standpoint, they can't manage that. And I would hate for this to be taken away from our community, because I think this is the reason why we have such a low infection rate, and we've been really successful at flattening the curve. So I will definitely be supporting this. And I thank you and others for your hard work and taking the time to explain this to us.
Sure. So this is not an easy decision, right? I mean, let's be honest, we're talking about spending a substantial amount of money on this. One thing I will add that makes this valuable, that makes it really worthwhile, is the fact that the test turnaround is, 24 hours or less, right? I mean, the same day results. I mean, that's really what makes testing impactful, is because, quickly. I'm not going to say what name, but if you go to an adjacent county right now and you get your test ordered by your doctor, you're going to wait 6 or 7 days. You're not getting that. You're getting it. You go at 8 today, you're going to get it by 1 or 2 today. And that makes a huge impact in terms of the ability to monitor the disease and be able for people to know. It creates less time where there's folks that could be contagious that are not, because they're able to get quick results, or they're able to identify earlier. So all of that combined, I think, adds value to it. Frank and I talked a lot over the weekend about bringing this forward and whether or not it was the right thing to do. And, it wasn't anything we took lightly. I wish you were here to talk a little bit more about it, but he will be for tonight's meeting. So, we think it's the right thing to do, not an easy thing to do. We understand that. We understand the financial impact to it.
Mike, okay, I see Dave, and then Mike, I can't see your hand. Give us.
I'll let Dave go, then I'll speak.
Okay, thanks. All right, Dave.
Yeah, I think it's a good thing, and I'm willing to support it. The side benefit to this is that the fewer people that get sick, the fewer people that are going to be in the hospital, that could cause both overcrowding and a financial strain on the hospital with bills not getting paid, because hundreds of $1,000s worth of bills for being in there for a hell of a long time. Anyone we can catch, that just saves an awful lot more people. And I can't figure out how many that is, but I know it's more than one extra one. So, if it's 10 people, it's 10 people for every one you catch. And I just think it's a really good thing. So, it's going to cost us some money, but I think the savings is going to supersede the amount that we lose.
Mm-hmm. Thanks, Dave. Mike?
I thought Dan Corman made a lot of good points about free stuff. When things are free, people will tend to use them, sometimes overuse them. So I've been leaning towards saying we ought to charge something. On the other hand, we're talking about 10 weeks in this resolution. And my big question is, what happens at the end of 10 weeks? Do Frank and Jason and Dr. Stallone come to us and say, oh, we need another 300,000 because things are just starting to pop and we want to be able to do this, especially with IC now reopening or Cornell now reopening or TC3 now reopening. We've got to be doing even more testing. Now I realize that they're supposed to be doing their own testing, but you can be sure that there will be people coming into our facility. So I'm willing to gamble $300,000 of taxpayer money in hopes of getting FEMA reimbursement, take that burden off the hospital for 10 weeks. But I certainly am not going on at this point and saying I would support that for a longer period of time. So we might want to consider when that 10 weeks starts.
All right, so good points, Mike. And I think several things that we would do, assuming we can continue it moving forward, let's say it starts September 1st and we're able, and that would carry us to about the beginning of November, November 10th, November 11th. You know, one of the things we would do is we would start submitting reimbursements probably after the first or second week. We have to wait for a certain threshold before we submit reimbursements to FEMA. We would then track it, we would then monitor it, and we would know within several weeks of that first submission, which would then have subsequent second submissions and third submissions as to what's the turnaround for it. And then we can start to understand, hopefully by that time, whether or not the state's going to follow through with a 12.5% or not, and other elements that go into this. We'll know 10 weeks away is a long ways away right now compared to the way things have been happening. So my point is we would monitor it. We would see the amount of participation on a weekly basis. We would know when we submit. We would be able to track that submission. There's some legwork on us that we would be able to report out into the first few weeks of this to be able to get an understanding of, all right, will this amount of funding last us well beyond 10 weeks? Will it not? What's the demand for it? Things we will know more about how the community is reacting to some of the reopening plans, and we'll have to make a decision from there. So I think this, you'll get information as we go into this as to how things are progressing, and you'll know, a lot more information before the 10-week mark comes up. So if there's another decision to be made, we'll know. We'll have good information available about what this initiative does and what it doesn't do.
Amy, is that you in the corner at the end of that table?
Yes,
I
I'm
see
here.
Okay, just wasn't. Thought maybe I see this big table and I thought, oh, that's Amy at the back. Did you have anything you wanted to add?
No, I think Jason covered it all. I think this is a solid proposal that we went through a lot of different options. It's taken a long time to get us to here. As Jason mentioned, we started these discussions in July trying to figure out other ways to do this. And this is where we're at if we're looking at this community testing for our community.
Okay. Thanks, Amy. I am inclined to lean very heavily on the public health recommendation. That the public health director is recommending that we do this. As Dave said, kind of every person that we catch that's asymptomatic, or any individual that we catch, especially who wouldn't otherwise get tested, is that we're that much closer to a full recovery because we've really containing the disease. And and we've seen this around the country, there's no shortcut to containing this disease. You have to find the people who have it and make sure they're separated from other people. So I'm certainly persuaded it's the right thing to do, and I want to remove barriers to getting as many people tested as we can. I would say that it's very helpful to know that you can identify 40 cases, 40 people who are asymptomatic. That's a significant number. When you do the math and think of how many more cases those 40 people would have created if they had not been identified and separated. And the fact that charging a local cost to our residents doesn't actually save our budget anything, but saves the federal government budget. I'm not persuaded by that. The federal government should be doing more for local governments and not less. So I don't think charging as a way of constraining, this is not like we're giving out candy here. I don't think people are going to be seeking testing just for the fun of it. There are a couple things on the resolution itself. I wanted to identify. I know that Anna sent a couple of corrections for the very end of it. I'm looking at 1, 2, 3, 4, 5, 6, 7, the seventh whereas. I think there are 2 that's that don't need to be there. It should say science has demonstrated that there are many asymptomatic individuals. Take out the that at the beginning of that line and the that at the beginning of the next line as well. Kathy, is that okay? Got that?
So it would read, but that science has demonstrated there are many.
Yep.
No,
Okay. And
take out the that. I think
right.
it is possible to control the spread of COVID, but science has demonstrated that there are asymptomatic individuals, and the early availability of surveillance has played a significant role. I don't think you need the 2 that's. I mean, I'd be willing to have somebody else read it, but when I read it, it seemed that those 2 words were actually misplaced. In the whereas above that, where they talk about CHS has tested over 65,000 individuals. It's in your information in one of your emails, that's incorrect, right? There have been over 65,000 tests.
They've administered over 65,000 tests. Yeah, that's probably a better way of categorizing it. So it probably should say, and today CHS has administered over 65,000 tests in Tompkins County and the broader region.
Right, because we cannot, people get at least 2, if you're positive, you get at least 2 more tests following that to where you're not considered recovered until you've had 2 negatives, correct?
Yeah, so I mean, I was taking this data set from Cuga Health Systems online page, and it does identify tests, not individuals. So, you know, I think that your identification that it should really be it's actually 67,000 now. More than 67,000 tests have been administered.
Okay, so it should say CHS has administered more than 67,000 tests. In like for residents in Tompkins County and the broader region, right? So
I would just say in Tompkins County and the broader region, because
okay.
You know, believe it or not, there's actually folks from well outside the region that have also gotten tested. But I think that captures what you're trying to say. I mean, the point is you're articulating they've done a lot of testing.
Right, but they're not testing anywhere outside Tompkins County. Those people are coming here.
Right.
Okay. All right. So if you have that, Kathy, that's.
Yes, I do.
Okay, great. All right. Is there anything else for us right now? And any other questions on this? All right, not seeing any. Are we ready with those slight changes? Are we ready to vote on the resolution? Okay, I'll start with Dave McKenna.
Yes.
Shauna Black.
Yes.
Mike Lane. Mike Lane.
Yes.
And I'm a yes. So that is unanimous for the members who are here. And is there anything else you wanted to share, Jason? We will pass this on to the full legislature in about an hour or so. Anything you want to add?
No, I think what'll end up happening, I know Kathy or Leslie will explain, I think we'll have to go to closed session and then come back out and take action at the end of the meeting. Is that how we're going to approach it, Kathy?
Yes, and it'll be done at the end of the meeting.
Okay,
The resolution will be pushed off till after that.
okay. All right, great. Well, thank you very much, Jason. Thank you for your work on this, and Amy as well, and for answering our questions very quickly.
Sorry.
We understand there's a lot going on, but we appreciate having the extra information. All right. All right, then I'll consider the meeting adjourned and see everybody in about 45 minutes. Thank you very much.